Welcome back to the deep dive. Today, we are cracking open one of the most vital foundational texts in clinical nursing, Brunner and Sudworth's essential chapter on the renal and urinary systems.
Mm.
Our mission isn't just to skim the surface. It's to give you the most comprehensive, structured roadmap possible for mastering this material.
Yes.
Think of this as your shortcut to understanding the kidney, not just as a filter, but as the body's ultimate master regulator.
That is the perfect framing. I mean, when we discuss the renal system, we are looking at the body's primary supercomputer dedicated to maintaining homeostasis.
Homeostasis, that's the key word.
It is. Its job is relentless.
Mm.
Strict regulation of fluid, electrolytes, and acid-base balance, removal of all metabolic wastes, and the crucial systemic control of blood pressure and even red blood cell production.
Wow.
Truly understanding its anatomy and its complex mechanisms is, well, it's fundamental to every aspect of patient care, regardless of specialization.
Absolutely. So to guide our discussion, let's nail down a few foundational concepts right away. We need to be speaking the same clinical language.
Good idea.
When we refer to the structural and functional units, the tiny filtering engines nestled inside the kidney, we're calling those the nephrons.
The nephrons. And if you want the single best metric to tell you how well those engines are running, you look at the glomerular filtration rate, or GFR.
GFR.
It is the volume of plasma that is filtered through the glomeruli per minute. It's the gold standard for function.
And on the flip side, we have the critical terms for when the system is failing. A dangerously low urine output is categorized as anuria.
Right. Anuria, which is defined as less than 50 milliliters in a full 24-hour period. It's a crisis.
And then there's oliguria.
Which is a bit more, but still highly concerning. Less than 400 milliliters in 24 hours, or if we look at the hourly output, which we often do, it's less than 0.5 milliliters per kilogram per hour, sustained over 6 hours.
Okay. And finally, let's keep the key hormonal controls front and center because they dictate fluid movement.
Absolutely. Antidiuretic hormone, ADH, you'll hear it called vasopressin. It acts on the tubules to force the reabsorption of water back into the circulation.
And the other big one.
Aldosterone.
Yeah.
Secreted by the adrenal cortex, and it governs the reabsorption of sodium. These two hormones are the critical levers the body pulls to manage volume and concentration.
Our goal now is precise. We're following the textbook structure exactly, guiding you through the intricate anatomy, the complex physiological roles, distinguishing normal versus abnormal assessment findings, and detailing the essential nursing implications of major diagnostic tests.
Let's do it.
Let's start with the blueprint itself.
Okay.
Let's unpack the core anatomy, where they sit, and what keeps them protected. If you were visualizing the kidney, where would you place it?
So these bean-shaped organs are placed posteriorly on the abdominal wall, specifically retroperitoneally.
Which means behind the main gut cavity, right?
Exactly, behind the peritoneal cavity that houses the intestines. They span the vertebral column from about the T12 level down to L3.
And there's a spatial quirk I remember reading about.
There is. The right kidney is consistently situated slightly lower than the left, primarily due to the large mass of the liver occupying the space right above it.
And considering how vital their function is, it just makes sense they'd be well shielded.
They are surprisingly well protected. Externally, you have the lower ribs and the posterior abdominal muscles, but internally, they are cushioned by a thick, protective layer of fat, the renal fascia and capsule, which helps stabilize them.
So it's not just floating around in there.
Not at all. This extensive protection tells you immediately that these are organs the body simply cannot afford to have damaged.
Now let's go inside and discuss the architecture of the renal parenchyma, the functioning tissue. We have two distinct regions.
We do. We split the parenchyma into the outer layer, the cortex, which is about 1 centimeter thick and is where you find the majority of the nephrons, the cortical nephrons.
And then deeper in.
Beneath that is the inner portion, the medulla. The medulla has a very distinct structure, organized into 8 to 18 triangular masses called the renal pyramids.
And those pyramids are functionally crucial. They're guiding the flow, right?
Exactly. The bases of the pyramids face the cortex, and the apexes, the papillae, point inward toward the center. This arrangement creates a kind of funnel system.
A funnel system. I like that.
The filtrate drains from the collecting ducts through the papillae into cup-like structures called minor calyces, which then converge into major calyces. These, in turn, drain into the renal pelvis.
And the renal pelvis is basically the on-ramp to the ureter.
It is. And it's so important to remember that once the filtrate officially becomes urine and leaves the renal pelvis, its composition is finalized. No further change occurs.
This structure supports a massive task. which means the blood supply must be enormous. How much of the body's output are we talking about?
An incredible volume. The kidneys process 20 to 25% of the body's total cardiac output.
Wow,
If you translate that, they circulate all of your body's blood approximately 12 times every single hour.
that's amazing.
Blood enters the kidney through the renal artery, which quickly branches down into the smaller afferent arterioles.
And the afferent arteriole is the gateway to the primary filter.
Yes, the afferent arteriole supplies the capillary network known as the glomerulus, where the actual filtering takes place. What's unique is that blood then exits the glomerulus not into a low-pressure venule, but into another high-pressure vessel, the efferent arteriole.
And that high pressure is key.
It's essential for maintaining the hydrostatic pressure needed for filtration. It's a very clever bit of engineering.
Let's focus on the nephron, the million tiny heroes in each kidney. What happens if we lose some of those?
The kidney is incredibly resilient. We start with about 1 million nephrons per kidney, giving us significant reserve capacity. Clinically, we maintain adequate function until the total functioning nephron mass drops below 20%.
And once you hit that threshold,
Once you hit that threshold, the system is overwhelmed, and replacement therapy, like dialysis, becomes a critical consideration.
and the sources differentiate between two types of nephrons. Why is that distinction important?
Well, the cortical nephrons, which make up 80 to 85%, are primarily focused on standard excretion. But the juxtamedullary nephrons are special.
What makes them so special?
They have exceptionally long loops of Henle and long capillary loops called vasa recta that dive deep into the medulla. The length of this loop structure is what gives the kidney its remarkable ability to concentrate urine and conserve water when needed. They're the water savers.
So the filtration itself happens in the glomerulus and Bowman capsule. Give us a functional analogy for that filtering membrane.
Think of it as a highly sophisticated three-layered sieve.
A sieve, okay.
The layers are the capillary endothelium, the basement membrane, and the epithelial cells. This membrane is engineered to be selectively leaky. It allows water, small molecules, and electrolytes to pass freely, creating 180 liters of filtrate daily.
But its structure is absolutely critical because it prevents the passage of larger molecules.
It clings fiercely to blood cells and large proteins like albumin. If you find albumin in the urine, it's a profound sign that this delicate filtration barrier has been damaged.
And just beyond the glomerulus, there's a vital structure that links the nephron directly back to the cardiovascular system.
That's the juxtaglomerular apparatus, or JGA. It's formed where the distal tubules, specifically the macula densa cells, snuggles right up against the afferent and efferent arterioles.
There's a sensor.
It's a sensor, exactly. This proximity allows the macula densa to sense the fluid composition and pressure. If pressure drops, the JGA acts instantly by becoming the specialized site of renin production.
Which, as we'll discuss, is the master switch for blood pressure control.
A master switch.
So when we look at the kidney's job description, it's not just a plumbing company. It's a massive chemical factory and regulatory center.
It absolutely is. Beyond urine formation and waste excretion like urea and creatinine, its regulatory functions are nonstop, maintaining strict electrolyte, water, and acid-base balance.
And then there are the endocrine functions.
Right. Controlling blood pressure through the RAAS, regulating red blood cell production via erythropoietin when it senses hypoxia.
Which is why anemia is a sign of kidney disease.
Precisely. And it even synthesizes the active form of vitamin D, which is necessary for calcium absorption and bone health.
Plus the local vasoactive controls.
Yes, the secretion of prostaglandins. These are crucial vasoactive substances that act locally to selectively dilate or constrict the afferent and efferent arterioles, helping the kidney maintain stable internal blood flow and filtration rate despite systemic blood pressure changes. It's all about protecting that delicate glomerulus.
Now we get to the core mechanisms. How does that 180 liters of raw filtrate get processed into just 1 or 2 liters of useful concentrated urine? And how is the chemistry adjusted along the way?
It happens in 3 distinct sequential steps within the nephron. Step 1, glomerular filtration.
Sure.
As blood pressure pushes plasma through that filtering sieve, about 20% of the plasma is filtered, creating that 180-liter daily volume.
So what happens if the patient becomes hypotensive?
Filtration depends entirely on adequate hydrostatic pressure. If a patient is in shock or severely hypotensive, the pressure gradient across the glomerulus drops, filtration fails, and you move rapidly toward acute kidney injury.
So blood pressure is everything for this first step.
Everything. Obstruction or very low oncotic pressure in the blood can also shut down this critical first step.
Step 2 is the body's sophisticated reclamation project, tubular reabsorption.
And this is the most impressive part, really. 99% of that 180 liters is pulled back into the bloodstream from the tubules.
99%.
This primarily occurs in the proximal tubule. Essential nutrients like amino acids, electrolytes, and water are reabsorbed, often through active transport mechanisms. We are literally saving everything useful that filtration temporarily stripped away.
This mechanism has a finite capacity, which brings us to the key clinical concept of glycosuria.
Right. Think of the tubules as having a limited number of shuttles or transporters for glucose. If the blood glucose level is high, say, exceeding 220 milligrams per deciliter, which is the tubular transport maximum, all the shuttles are busy.
So there's nowhere for the extra glucose to go.
Exactly. The excess glucose cannot be reabsorbed. It spills into the urine. That's why glycosuria is a classic sign of uncontrolled diabetes, signaling that the plasma load has exceeded the renal system's reabsorptive capacity.
And the final adjustment? Tubular secretion.
Secretion is the opposite of reabsorption. It's the last chance for the body to move unwanted substances, potassium, hydrogen ions, uric acid, drug metabolites, from the blood in the peritubular capillaries directly into the filtrate to be excreted.
This is how we fine-tune things.
Exactly. This is crucial for regulating potassium and, as we'll see, acid balance.
Let's discuss fluid regulation, specifically the role of ADH or vasopressin. We established that it makes the kidney save water. What is the trigger for its release?
The trigger is increased blood osmolality.
So when the blood gets too concentrated.
Precisely. This happens when the concentration of solutes in the blood is too high, usually because the patient is dehydrated. Specialized receptors in the hypothalamus detect this concentration and signal the posterior pituitary to release ADH.
And ADH goes to work on the tubules.
It acts on the distal and collecting tubules, making them highly permeable to water, which flows back into the blood. The result is highly concentrated urine and conserved water.
Here is the clinically vital connection. When the kidney is diseased, its ability to concentrate urine is lost. What signs should nurses look for?
It's the loss of variability. In a healthy person, specific gravity ranges widely from maybe 1.005 to 1.025 depending on hydration.
Yeah, okay.
A classic but subtle early sign of kidney disease is urine that loses its ability to concentrate or dilute. It gets stuck at a fixed specific gravity of approximately 1.010.
So it's always the same, no matter how much they drink.
Exactly. Or a fixed osmolality around 300. This means the kidney can no longer respond to the body's hydration needs. It's a critical warning sign that the nephron has suffered damage.
And since fluid status is so crucial, let's repeat the most reliable nursing metric for monitoring volume.
Daily weight measurement. It's simple but incredibly accurate. A change of 1 pound, or about half a kilogram, is roughly equivalent to 500 milliliters of fluid gain or loss.
That's a direct conversion.
It is. This makes daily weight a non-negotiable metric for anyone at risk for fluid volume issues.
Okay, let's dive into the powerful and complex renin-angiotensin-aldosterone system, or RAAS. This is the integrated control system linking fluid, sodium, and pressure.
This system is a phenomenal example of negative feedback. The entire cascade is initiated by the JGA detecting a threat.
A threat like low blood pressure.
Specifically, decreased pressure in the renal arterioles, which could be from dehydration, systemic hypotension, or low sodium chloride levels being delivered to the macula densa.
What happens when the JGA senses this threat?
It releases renin, a potent enzyme. Renin enters the circulation and acts on a substrate called angiotensinogen, which is produced by the liver, converting it to angiotensin I.
And angiotensin I is just the first step.
It is. It's relatively inactive, but as it flows through the lungs, it encounters the angiotensin-converting enzyme, or ACE, which converts it rapidly into angiotensin II.
And angiotensin II is the core action molecule here. What are its two primary effects?
Effect number 1. It is the single most powerful vasoconstrictor the body produces.
The most powerful.
Yes, it immediately causes widespread constriction of peripheral blood vessels, skyrocketing systemic blood pressure. Effect number 2, it stimulates the adrenal cortex to release aldosterone.
And aldosterone's job is to secure volume.
Correct. Aldosterone acts on the distal tubules and collecting ducts, causing the enhanced reabsorption of sodium back into the bloodstream.
And water follows sodium.
Water always follows sodium via osmosis, so the intravascular fluid volume increases significantly, stabilizing blood pressure and restoring adequate hydrostatic pressure for GFR. The clinical relevance is profound. Failure of this loop is a primary mechanism driving essential hypertension.
Which is why so many blood pressure meds target this system.
Exactly. ACE inhibitors, ARBs, they're all designed specifically to disrupt this very powerful system.
Beyond pressure and volume, the kidney is also our long-term structural regulator for acid-base balance, maintaining serum pH between 7.35 and 7.45.
This is a major regulatory function that complements the respiratory system. The lungs handle volatile acids, like CO2, but the kidney handles the non-volatile acids,
Like what?
primarily sulfuric and phosphoric acids, which are byproducts of protein catabolism. The kidney maintains pH in two crucial ways.
Way number one, bicarbonate management.
The kidney is constantly recovering and manufacturing our base stores. It must aggressively reabsorb nearly all the filtered bicarbonate from the tubular filtrate and transport it back into the circulation.
And if the body is in acidosis.
It also generates new bicarbonate to help restore balance.
And way number two, excretion of those non-volatile acids.
Since we can't exhale these strong acids, the kidney secretes them into the urine. To prevent the urine from becoming dangerously acidic and damaging the tubules, the kidney cleverly binds these excess hydrogen ions to chemical buffers.
Buffers that are already there.
Exactly. The two main buffers it uses are phosphate ions and ammonia. Ammonia binds the hydrogen ions to form ammonium, allowing large amounts of acid to be excreted without significantly lowering the urine pH. It's a marvel of chemistry.
Finally, let's revisit renal clearance and GFR. We said creatinine clearance is the practical measurement of GFR. Walk us through why creatinine is such a great marker.
Creatinine is ideal because it is an endogenous waste product. It's always being produced at a relatively stable rate based on muscle mass.
So it's predictable.
Very. And crucially, it is filtered freely by the glomerulus and is only minimally secreted or reabsorbed by the tubules. Therefore, the rate at which creatinine appears in the urine gives us a highly accurate measure of how much plasma the glomeruli are clearing per minute.
And the calculation requires both a 24-hour urine collection and a single serum sample.
Yes. The formula is designed to compare the concentration of creatinine in the urine against the concentration in the serum over a specific time period. The normal GFR is approximately 125 ml per minute.
And as function declines, that number drops.
It drops proportionally. The clinical takeaway is non-negotiable. A decline in creatinine clearance is a direct indicator of declining renal function.
And let's quickly connect the two common blood tests, BUN and creatinine, using the BUN to creatinine ratio.
This ratio, normally 10:1, is your quick clinical detective tool. Remember that creatinine is stable, but BUN, blood urea nitrogen, is highly variable.
Affected by diet, hydration.
Dehydration, high protein intake, tissue breakdown, you name it. So if you have an elevated ratio, say 20:1, that means BUN is disproportionately high compared to creatinine.
What does that tell you?
Since dehydration affects the renal blood flow, a pre-renal cause, the kidney reabsorbs more urea to save water, shooting the BUN up. An elevated ratio means think dehydration first.
And if the ratio is normal, but both are high.
If, however, both BUN and creatinine are elevated, but the ratio remains 10:1, it points strongly to intrinsic kidney disease. The filter itself is broken.
So the master regulator has finished its job. Now we look at the plumbing that takes the finished product out. We start with the ureters.
These are the muscular transport tubes, 24 to 30 centimeters long, running from the renal pelvis down to the base of the bladder. They are lined with urothelium.
Which is a special kind of tissue.
It is a type of transitional cell epithelium which has one primary job: to be impermeable. It absolutely must prevent the reabsorption of any urine back into the bloodstream.
And where are the common trouble spots?
Obstruction is the major risk here, primarily from kidney stones or renal calculi. There are 3 natural narrowings prone to obstruction, with the ureteropelvic junction, where the ureter exits the kidney being the most critical.
Why there?
Because a blockage there causes immediate pressure backup and risk of hydronephrosis, which is swelling of the kidney.
Next, the bladder, the storage tank.
A highly distensible muscular sac resting behind the pubic bone. Its adult functional capacity is typically 400 to 500 ml. The wall is composed of 4 layers, the most prominent being the detrusor muscle.
The detrusor muscle, that's the engine.
That's the main engine, the smooth muscle layer that contracts powerfully to expel urine. Continence is a dual mechanism act. The involuntary internal sphincter at the bladder neck and the voluntary external sphincter located in the anterior urethra.
How does the brain know when to empty?
Well, the filling phase is compliant and low pressure. As volume increases, stretch receptors activate. The first conscious desire to void is usually sensed at 150 to 200 ml.
And then you start looking for a bathroom.
Exactly. Fullness and discomfort set in around 400 to 500 ml. This low-pressure filling is essential, and any high-pressure filling is a danger sign, often caused by obstruction.
And the physics of voiding micturition is a highly coordinated event.
It really is. It requires the efferent pelvic nerves from S1 to S4 to simultaneously signal the detrusor muscle to contract powerfully while the external sphincter is signaled to relax completely.
And if that coordination is off,
any interference in this neurogenic pathway, like a spinal cord injury or diabetic neuropathy, can cause discoordination, leading to incomplete emptying.
which brings us to a crucial assessment metric, residual urine.
That's the volume left after voiding. Normally, we want to see less than 50 ml in middle-aged adults. Finding significantly more suggests decreased detrusor contractility or, more commonly, an outlet obstruction.
Like an enlarged prostate BPH.
That's the classic example.
Here's where it gets really interesting because the system fundamentally changes with age. Let's spend significant time on the gerontologic considerations.
This section is absolutely critical for nursing practice. The decline in kidney function starts early, around age 35 to 40, decreasing by about 1 ml per minute per year thereafter.
So it's a gradual decline over decades.
It is, and this means the older adult has significantly decreased renal reserve. If they encounter a stressor, a new nephrotoxic drug, a severe infection, or a hypotensive episode, their ability to compensate is drastically diminished.
Which puts them at higher risk for injury.
A much higher susceptibility to acute kidney injury and adverse drug effects because clearance of metabolites is slower.
What about the thirst mechanism and hydration? This is a huge one.
It's a major risk factor for dehydration. Aging significantly diminishes the osmotic stimulation of thirst. The body's alarm bell for concentration is blunted.
So they don't feel thirsty even when they need water.
Consequently, older adults don't feel thirsty even when they are physiologically dehydrated, putting them at high risk for hypernatremia and fluid volume deficit. The nursing takeaway is paramount. We must proactively educate older patients to sip fluids throughout the day following a schedule, rather than waiting for the sensation of thirst.
And structural changes in the bladder lead to that common complaint, nocturia.
Yes. Bladder compliance decreases, meaning it can't stretch and hold volume as easily. Coupled with a decrease in nighttime vasopressin release, you get increased diluted urine production at night, leading to frequent nocturia.
Which just wrecks their sleep.
It severely impacts sleep and quality of life.
We also need to consider incomplete emptying and what that entails for long-term risk.
Incomplete emptying, whether due to decreased detrusor contractility or BPH, causes urinary stasis. Stasis is a breeding ground for infection.
The perfect environment for bacteria.
It is. It's the primary reason older adults have higher rates of UTIs, which can rapidly progress to urosepsis. Furthermore, long-term obstruction increases pressure, leading to hydronephrosis and eventually chronic kidney disease.
And a major clinical warning, how urologic symptoms can be misleading in the older patient.
Due to decreased neurologic innervation and altered pain perception, a serious urologic condition in an older adult might present with vague, non-specific abdominal discomfort. For instance, flank pain or a kidney stone could mimic a serious GI disorder like appendicitis or cholecystitis.
Making it much harder to diagnose.
Much harder, and the stakes are higher.
We now move to the clinical floor. As nurses, our primary tool is assessment, starting with history. How do we approach such a sensitive and often embarrassing topic with patients?
The foundation is professional, empathetic communication using clear, non-jargon language. We have to make the patient comfortable enough to discuss private functions like voiding habits and incontinence type. Without an honest history, we miss crucial data.
What are the key elements we must inquire about in a comprehensive history?
Well, the chief concern, the onset and location of pain, specifically asking about dysuria, or painful urination, any history of UTIs, fever, chills, previous procedures, the presence of hematuria, and then detailed voiding symptoms.
Like what?
Frequency, hesitancy, and the exact type of incontinence. Is it stress, urge, overflow? We need the details.
And we must cross-reference this history with known risk factors.
Recognizing risk factors is proactive nursing. We already discussed advanced age and UTI risk. You must link conditions like diabetes, which is a risk for chronic kidney disease and neurogenic bladder, hypertension, which leads to renal insufficiency, and even remote infections.
Like strep throat.
A recent strep throat or impetigo can actually precede nephritis, so you have to ask about it. And if the patient has BPH, you know obstruction is a major possibility if they report frequency or hesitancy.
Let's use the pain descriptions to teach the listener how to differentiate the source of pain. The sources note that severity relates to the suddenness of onset, not the extent of damage.
That's a crucial distinction. Kidney pain is typically located at the costovertebral angle, or CVA.
That spot on your back at the bottom of the ribs.
Exactly. It's often described as a dull, constant ache. If it suddenly becomes obstructed, maybe by a stone, the character changes immediately to severe, sharp, stabbing, and colicky pain, often radiating to the groin.
And that's when you get the nausea and vomiting.
Frequently, yes, sometimes even signs of shock.
And lower down the tract.
Bladder pain is localized suprapubically, dull and continuous, intensifying with voiding or urgency. Ureteral pain is also severe, sharp, and colicky, felt in the flank, CVA, or lower abdomen, and tends to be migratory, moving as the stone progresses.
And prostatic pain.
Prostatic pain is more vague, a sense of fullness or discomfort in the perineum and rectum.
Discussing changes in voiding requires precise definitions for the patient record.
You must accurately document the abnormal patterns. Anuria is the extreme, less than 50 ml a day, implying complete obstruction or catastrophic kidney failure.
That's an emergency.
A true emergency. Oliguria, less than 400 ml in 24 hours, is also highly concerning for injury or dehydration. Frequency means voiding more often than every 3 hours, and its cause could be infectious, obstructive, or psychological.
And the clinical priority alert regarding retention.
If the patient reports increasing urgency and frequency, but their voided volumes are simultaneously decreasing, the nurse must suspect chronic urine retention. This requires immediate intervention, often catheterization, to prevent pressure back up into the ureters and kidneys.
Which can cause permanent damage.
Permanent damage, absolutely.
Why do urologic conditions cause so many seemingly unrelated GI symptoms?
It's the shared anatomy and nervous system wiring. The right kidney is nestled right next to the liver and duodenum, and the left kidney near the stomach and spleen.
So they're all neighbors.
They are. When the kidney is inflamed, distended, or infected, the resulting autonomic stimulation causes reflex symptoms like nausea, vomiting, and diarrhea. This GI presentation can unfortunately delay the correct diagnosis.
Finally, the subtle red flag, unexplained anemia.
Yes. If a patient presents with chronic unexplained fatigue, shortness of breath, or exercise intolerance, the nurse must consider kidney dysfunction. The kidney's failure to produce adequate erythropoietin leads to what we call anemia of chronic inflammation, or anemia of kidney disease.
And it's an insidious sign.
Extremely insidious, but also an extremely reliable sign of gradual decline.
Moving to the physical assessment. The kidneys are usually a non-finding, not palpable.
And if they are palpable, especially if significantly enlarged, it is a key positive finding suggesting a mass, a tumor, or hydronephrosis.
And how do we check for tenderness?
We assess for CVA tenderness by palpating or lightly striking the CVA with a fisted hand, which suggests underlying renal inflammation or infection.
And we must not forget auscultation.
Absolutely. You listen over the upper abdominal quadrant, slightly lateral to the midline, for a vascular bruit. A bruit suggests turbulent blood flow, most commonly due to renal artery stenosis.
Which can be a key driver of hypertension and renal failure.
And the major driver.
How do we assess the bladder for retention, especially post-voiding?
We rely on percussion. Starting above the umbilicus and moving downward, we listen for the sound to change from tympanic over the air-filled bowel to dull over the fluid-filled bladder.
And if it's still dull after they've voided?
If the bladder remains dull after the patient has attempted to void, we have confirmation of residual urine.
And the high-tech, non-invasive adjunct to percussion?
The portable bladder ultrasound, or POCUS. This is a game changer. It is non-invasive, can be used at the bedside, and provides an immediate, accurate, estimated volume of residual urine.
And the sources say this actually improves outcomes.
They do. Using POCUS for post-void residual checks has been proven to significantly reduce the rate of catheter-associated UTIs and unnecessary catheterizations in vulnerable populations.
Finally, we connect the dots between the lower tract and the neurological system.
The sacral nerves, S1 to S4, govern both leg reflexes and bladder function. Therefore, checking the deep tendon reflexes of the knee and assessing gait pattern are essential components of the renal assessment.
So it's all connected.
It's all connected. If a woman reports stress incontinence, the Marshall-Bonney maneuver supporting the urethra during a cough can help the nurse determine if the incontinence is due to lack of urethral support.
Moving to diagnostics requires a shift in nursing focus, from data gathering to detailed patient education and preparation.
Absolutely. Procedures related to the urinary tract are often highly embarrassing or anxiety-provoking. We have to explain every step clearly, confirm understanding, and ensure they know how to manage post-procedure symptoms.
Let's start with the most basic yet informative test, urinalysis and culture.
The urinalysis is invaluable. We check color pink or red, could be hematuria, but it could also be dietary from beets or from a medication like phenazopyridine, which turns urine orange.
What about milky white?
Yellow or milky white often suggests pyuria, or white blood cells, which indicates infection. We check odor, pH, and clarity. Cloudy urine, for instance, often indicates bacteriuria, pus, or renal calculi.
And the crucial microscopic components.
We look for red blood cells, which is hematuria. Any count over 3 RBCs per high-power field demands further evaluation for infection, a stone, or a potential neoplasm. We also look for white blood cells, or pyuria, and casts.
Casts are a big one.
A very big one. They're protein molds of the renal tubules that strongly suggest intrinsic kidney disease.
Detail the importance of screening for protein and glucose.
Glucose presence, or glycosuria, usually suggests uncontrolled diabetes. Proteinuria is more complex. While a dipstick is a decent screen for early kidney disease, we need to screen for microalbuminuria.
Which is a very small amount of protein.
Exactly, 20 to 200 milligrams per deciliter. This is an early critical sign of diabetic nephropathy, signaling subclinical damage to the glomerular sieve.
We've discussed fixed specific gravity, but let's reinforce why osmolality is a more accurate measure of concentration ability.
Specific gravity measures weight. Osmolality measures the number of solute particles per kilogram of water. It is simply the more accurate measure. We compare the serum osmolality against the urine osmolality.
And what does that tell us?
This comparison confirms the kidney's ability to concentrate water effectively, a measure that is often lost early in disease.
Moving to the critical blood tests, we already expanded on serum creatinine and BUN, but let's re-emphasize the stability of creatinine.
Serum creatinine is reliable because its production rate is stable. An increase from 1.0 to 2.0 milligrams per deciliter represents a 50% loss of renal function. It doesn't fluctuate much based on diet or hydration, which is why it is the anchor for measuring function.
Unlike the BUN.
Exactly. It contrasts sharply with the highly variable BUN.
Now for the imaging studies, KUB and general ultrasonography are the starting point.
KUB, or an X-ray, gives us size, shape, and position. Ultrasonography is non-invasive, uses sound waves, and is excellent for detecting masses, fluid, and hydronephrosis.
And a key nursing intervention for an ultrasound.
The patient must usually have a full bladder for optimal imaging of the lower tract. That's a key piece of prep.
CT and MRI offer phenomenal cross-sectional views, but this is where the nursing caution concerning contrast agents becomes paramount.
This is a major safety alert. Contrast agents are potentially nephrotoxic, especially to patients who are older, already have chronic kidney disease, or conditions like multiple myeloma.
And there's an allergy risk.
A huge one. They are often iodine-based, so we must meticulously screen for iodine or shellfish allergies. The core nursing intervention is pre-procedure 5E hydration to help flush the dye and minimize renal damage.
What should we warn the patient about regarding sensations during the infusion?
It's often alarming if they aren't prepared. They will likely feel a temporary sensation of intense warmth or flushing across the body, a metallic or seafood-like taste in the mouth, and perhaps temporary nausea.
But it's temporary.
Usually transient, yes, but preparation minimizes distress.
And the non-negotiable safety rules for MRI.
No metal. The magnetic field is immensely strong. This means removing all external metal jewelry, credit cards, metal-backed medication patches, and crucially, we must screen for internal metal.
Pacemakers, clips.
Pacemakers, cochlear implants, certain surgical clips, and older aneurysm clips are absolute contraindications, as the magnetic field can dislodge or damage them.
Describe the procedure that involves tracking the contrast agent through the entire system via X-ray.
That's IV urography, or IVP. The contrast is injected intravenously, and serial X-rays are taken to visualize the entire tract. It gives a rough estimate of function and can identify space-occupying lesions.
And if that's not enough,
If the IVP is inadequate, they may proceed to retrograde pylography, where the contrast is injected backward directly into the renal pelvis via a catheter inserted during cystoscopy. This gives superior visualization but carries a higher risk of infection or perforation.
to visualize the vascular supply, they perform a renal angiography. What are the post-procedure nursing priorities for this arteriogram?
Since the catheter is threaded into the renal artery via a peripheral access site, usually the femoral artery, the post-procedure care is focused on hemorrhage and circulation.
So checking the site and vital signs.
We monitor vital signs for hypovolemia, check the injection site meticulously for hematoma, and most importantly, perform frequent, meticulous checks of the distal peripheral pulses. You must compare the color, temperature, and pulse strength of the involved extremity to the unaffected side to immediately detect any sign of arterial occlusion.
Finally, let's detail the endoscopic procedure. Cystoscopy.
Cystoscopy involves direct visualization of the urethra and bladder using an illuminated scope. It's used not only for diagnosis, but also for interventions like biopsy, stone crushing, and removal of small tumors.
And the anesthesia.
For lower tract scopes, they may use viscous lidocaine for comfort. If the scope needs to access the upper tract, the ureters, general anesthesia is often necessary due to the risk of muscle spasm.
What are the expected and concerning post-procedure findings?
Expected findings are transient. Burning upon voiding, blood-tinged urine, and frequency. We manage this with moist heat or warm sitz baths and often prescribe antispasmodic agents.
And the critical concern.
Urine retention, especially in men with BPH due to urethral edema caused by the scope. We must monitor intake and output closely. Catheterization may be required if retention is confirmed.
And the most invasive diagnostic, the kidney biopsy.
This is reserved for diagnosing serious issues like unexplained AKI or chronic proteinuria, or to evaluate transplant rejection. Nursing preparation is intense. First, we must confirm coagulation studies are normal.
And there are contraindications.
Yes, uncontrolled hypertension, severe bleeding tendencies, and having only a solitary kidney.
How does the patient prepare for the needle insertion itself?
The patient is positioned prone with a sandbag under the abdomen to help stabilize the kidney. The most crucial patient teaching is this. The patient must take a deep breath in and hold that breath during the exact moment of needle insertion.
Why is that so important?
It prevents the kidney from moving during the respiratory cycle, minimizing the risk of laceration.
And post-procedure care focuses almost entirely on hemorrhage risk.
Absolutely. The patient is placed on strict bed rest, sometimes for up to 24 hours, and pressure dressings are applied. The nurse must monitor vital signs frequently, looking for pallor, dizziness, or intense flank or back pain, which are classic signs of retroperitoneal bleeding.
What about their urine?
Some bloody urine is expected for the first 24 to 48 hours, but prolonged or heavy bleeding must be reported immediately. We also encourage fluids to help clear the urinary tract. So to summarize this deep dive, remember that the kidney is a complex multitasker. It runs the body's chemistry by meticulously regulating fluid, blood pressure via RAAS, and oxygenation via erythropoietin.
Right.
Your mastery of the system hinges on understanding that GFR and creatinine clearance are the functional indicators, and that simple clinical measures like daily weight and assessing for fixed specific gravity provide powerful insights into status.
So always maintain vigilance.
Always maintain vigilance for subtle changes in voiding patterns or fluid status, especially in the older adult population who are highly susceptible to hidden dehydration.
We've navigated the architectural marvel of the nephron, tracked the 3 steps of urine formation, and detailed the nursing application of every major diagnostic tool. It really is a system of beautiful complexity.
And here's a final provocative thought for you to carry into your clinical practice. Because the kidney is so central to blood pressure control through the renin-angiotensin system, virtually every drug we use to manage hypertension has a direct, profound impact on renal function.
So as you move forward, consider the intricate balance. How does managing a patient's chronic hypertension with a drug that modifies the RAAS inadvertently create a new dependency or risk within the renal system? It forces you to monitor not just the patient's blood pressure, but their creatinine clearance, fluid status, and electrolyte balance constantly, recognizing the kidney as the great integrated monitor of the entire body. Thank you for joining us for this deep dive into the renal system. We look forward to helping you unpack your next stack of sources.